There's 4 options. I try to keep things. I do the 2 o'clock in the morning thing. So 2 o'clock in the morning, you've got a trauma come in, okay, and they're really super sick. They're not talking to you anymore, and you've got no idea what's wrong with them. They've got bruises everywhere. One hand's wrangled off a bit. They look like a mess, and they're unconscious, okay. And you're like, okay, cool. So it's not the time to be thinking about rib spaces and, oh, what's my options here? You kind of want something fairly simple. So I've got rules of 2 o'clock in the morning. What do you do? And then, we'll call it the daytime, but in a time when you're not stressed and things, you can just spend some time, make sure it's clean, make sure you get it right. And so there's 2 options for both. What's your 2 really big emergency options for a person who's got something in their chest that you want to get out of the chest, either air or blood, or fluid, I should say. But keeping it simple for me, this is how I see it. If I've got someone who I think has got a tension pneumothorax, who I want to empty out quickly, I'm going to put a needle in. It's so quick, and it's the least invasive, quickest thing to do to get a tension to stop, okay? But if there's blood in there, does a needle work? If there's a tension, no, a bit of blood, but if there's a tension pneumothorax, which most traumas are going to be, is a needle going to really decompress the blood? No. So I've got blood, which, the person didn't come in too bad, or maybe it wasn't too bad at the time, and it slowly got worse and worse and worse, and now they're obtunded, now their blood pressure's dropped, because that blood has filled up a bit slower than air does potentially, but it's filled up and now it's pushing across, and no little needle decompression is going to help. So it's a finger job. And that's all. I don't have to think too hard. That's all I've got to do. And then whether I put a chest drain in, whether I put a pigtail in, whatever, that can wait. That can wait for me to have a think about it, de-stress a bit, and look up YouTube. No, call a friend, whatever. But there's emergencies and there's emergencies. Okay, so let's do fingers first. Okay, I know there's the triangle of safety, but being really practical, I think 2 o'clock in the morning, I never remember the triangle of safety. Where do you put your finger or a chest tube? Like, how do you know where here to go in someone's axilla? Because it doesn't matter. Perfect. So hairline's a really good start. I'd go a little bit above where the hairline ends. I wouldn't go where, I'd go a little bit above the hairline, but yep, or where a nipple would be if it was a guy. And girls are old people, old women and young girls, they're all, you can imagine where a nipple would be in a guy and that person. It sounds dumb, but at 2 o'clock in the morning when you're stressed, if this was a guy, it looks like a guy or a girl, it's exactly the same thing. I expect the nipple to be here, bang around, and a bit further up. But I like the hairline the most. That's probably my favourite one. And if you're in doubt, go further up. No one's going to go up here. No one's going to go in the upper arm. So when you say further up, if it's there or if it's there, it doesn't really matter. If it's this much here or there, it makes no real difference. You don't want to be down here, because lots of people go, oh, that'd be about right there. But if I've now got my lungs really if I've got I'm not taking any breaths at all, I might actually have diaphragms up here, which I can pop through, or something else I might pop into. What's that? Liver or spleen. Yeah, and this is gross. You don't want to put your finger into liver or spleen. So how do I do it? This is my thoughts. So it should be quick. So scalpel. So scalpel in the rib station. You want to go between the 2 ribs, and here they're kind of straight, really. And you don't need a local. You're not doing a finger on a person who's talking to you. You're doing a finger on a person who's in extremis. If they're talking to you, I'd probably stop and do a chest drain instead. So pop through the skin, not this here. So make sure you pop through the skin. You don't want to do this. So pop through the skin, pop, and then you want one cut across. You don't want to do lots of cuts and sort of seesaw, cut across. And a good cut, like that's a good 4 or 5 centimetres. That's good, at least 4 centimetres there. So once that's done, I'm going to put my finger in. And my problem is everyone's a bit different. Some people can just get down to the ribs like this. I can't. I can be honest, I can't do it. But some people can just squeeze in. I get to a point where all these little intercostal fibres and muscles, and then it just gets in my way, and I just get squashed up and I push against nothing. I'll give it a go always. I always put my finger in and have a feel, but it doesn't go any further. So then I usually get the sharp scissors, but these are fine. The little fine scissors are even better. But I don't cut. What do I do? Blunt the section open. And then what you'll find, some people, the trick you got to do, if you see someone doing it and they're doing that, what they're doing is they're not pushing forwards. So when you open it, you got to push. So push. So go in with it closed a little bit until it stops. Just gently go in until you feel a resistance, and then push in as you open. But the trick is to push in as you open, not just open, because otherwise you open, you pull yourself out. You're doing this the whole time. So hit, it stops, then you push in. And you've got to be quite forceful and push in. It doesn't take, a few times. It doesn't take 3 or 4 times before you're actually quite deep in the chest. You just want to get to the ribs at the end of the day. Push, and then you think, okay, I'm probably about where the ribs are. I'll come out, and that's much easier. And my landmark is what? What do I want to be able to hit with my finger? So I've now hit the ribs. Oh yeah, pleura is what I want to get to, but I'm getting close enough for my ribs. So I've got to my ribs. If they're broken, they'll be sharp. Be really careful. I'd probably want to choose a different rib space. I've not had that yet, but it's a great way to cut yourself. I wouldn't put my finger through broken ribs because you'll cut yourself. And if they've got hepatitis, now I'm there really quick. So I can feel the rib above me. And now my problem is I want to get to the pleura. Now some people are a bit different. Here's like it's like a wall. I'm pushing against a wall. And that's what I'm feeling. Some people apparently can pop through it with their fingers. I've never been able to. I've never seen anyone do it, but apparently some people, I don't have strong enough fingers. So what most humans will get the same scissors or mosquitoes. I like mosquitoes more, but I use it, whatever I used to cut in, I used for this because it's just quick and it's just simple. So that there, and that sits just a bit above my finger. Just a smidgen. And I'm holding it really tight so it doesn't go anywhere at all, like really tight, okay? And then in it goes. There's the ribs, there's the brick wall. 1, 2, 3, pop. Okay, good hard pop, and you'll pop through that pleura, and it's a hard pop. What happens? What do you feel happen after that if it's a tension hemopneumo? Pressure, like a lot of blood and gas come out. So first time I did this, to my silly stories, I pulled it right out because I got a big shot of blood and gas, and I thought it got to the heart. I was pretty sure, oh my gosh, and I got laughed at. So yeah, so you expect it to get stuff to come out. That's why you're doing it. You expect a pressure effect of blood and gas to come out at you. So there we are. So now I'm in, and now I want to open it. So really sweep it open. If I can feel lungs, great, I can feel lungs. But I can't feel lungs, whatever. I know I'm in, I can feel space in there. I can feel the ribs further up on my finger. So open, and I'm done. That's it, finished. I don't have to put a chest drain in right now. I don't have to put a pigtail in. I can crack on, give blood, do resuscitation, get in the airway, go through my A, B, C, D, E again, or go through my 4H's, 4T's, depending on where I'm up to as far as the patient goes. But I don't do anything more than that. And that can take literally 30 seconds, if that, like 20, 30. Big person. Ask Harris about this one, where I was there at the ribs, okay? So I had to use a different, it can take a bit longer, it can take a minute, but that was still a minute, if that. If this is a neonatal resus, putting a needle in each side of the chest you'll do before you declare it. So you really, it doesn't matter what age they are. People always say, oh, I don't want to put a finger in, because if they're dead, they're going to be buried soon anyway. There's no harm in doing everything you can do to reverse things. So putting a finger in someone's chest who's having CPR done, you've got nothing to lose, honestly. It's like zero to lose, and you might just get ROSC from that alone. So needle's the other one. I'm not going to do that to someone who's got, so asthmatic comes in and they've got an obvious tension pneumothorax, or I've just tubed someone and I've caused an obvious tension pneumothorax. Let's talk about the tube on ventilators off. We'll just talk about someone who comes with obvious tension pneumothorax, okay? So you could put a finger in, and that will do exactly the same job. It's just a big hole for something you probably didn't have a big hole for, and it takes longer to do than a needle. So if you're happy it's a tension pneumo, just put a needle in. So you can put it in. I'll go through this one here. If you just want to remember one landmark, just go there. Forget this whole thing. Just go there. We still teach both, but but the distance to there is more than the distance to there. So if you can't reach it there, then you're going to go there with the needle. So the distance between skin and pleura is less often in many people there than there. Yeah, what's the landmark you use?
So you mean intercostal space, mid-clavicular line?
Yeah. It's a bit more lateral, isn't it? Because the clavicle starts a bit lateral, so mid-clavicular line's always a bit to the side. So say there-ish, so 1, 2, let's say it's there. What do? So I've got my syringe, got a bit of water in it, okay? And I've got a safety cannula. This is actually, it's actually a 14 gauge one. It's not a green one, but I take what I can get in Simland because I only get particular things. So that's a green one, but it's got the thing, oh, no, it doesn't anymore. It has a little thing on the end there, which I pull off, and now I've pulled it off now, okay? So everyone happy with that? There's a little bung at the end of your non-safety ones, and you pull that off because I want to put my cannula, my syringe on like that. Okay, so I've changed how I do this over time. What you're taught to do is put it in and it will bubble back when you're in the right place. I've changed that because it doesn't always bubble back depending on how much pressure it's in or if you've got it wrong. So I do the same thing as I do for anything else I'm seeking for. I go in and I pull back on the plunger gently until I get bubbles coming back. That's how I do it now. And if it helps me and pushes it back with me, great. But if I've got bubbles coming back and I'm in the pleural space, okay. But what you can do for lots of courses will say just put it in and the syringe will just go bubble, bubble, bubble backwards. And it happens most of the time for sure. But I've definitely had one where I nearly missed it because I thought I hadn't reached it, but I just was waiting for it to come back and it never came back. So I just keep it simple now and do the same thing for everything. Sitting in the intercostal space, I'm sitting trying to get just above the rib. So it is above the rib because the neurovascular bundle is below the rib. Gone through the skin, subcut tissue, pulling back, 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 plunger, 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 plunger. Oh, bubbles, bubbles. Can you see the bubbles? Bubbles coming back. Deploy my cannula, and that goes in. Out comes the needle, goes somewhere safe, and hopefully you hear it, some kind of hiss. And when the patient's breathing or being ventilated, you'll hear a hiss. So you hear some, you'll hear, yeah, I can hear something when they're being ventilated or when they're breathing for themselves. That's it. And then you can leave it. You can do you want to secure that. Some people with a styrofoam cup, I don't think so, gets in the way. There are some special dressings that are impossible to find when you really need them. Just watch it. I just tend to tape it, but I just watch it, honestly. You do so rarely, you do more fingers here than them, but just watch it closely if you do it. If it kinks off, you can put another one in, but they always say things don't fall out, they get pulled out. And I agree with that saying, same as tubes. Just watch it, make sure no one pulls it out. That's all. If it gets pulled out, put another one in. You don't need to put a chest drain in right now. You can leave it. That will do the job. That's detensioned it. And if they start going off again, you might think, oh gosh, maybe that's blocked or kinked. But usually that's good enough until you come back to it. They're going to need a chest drain of some type though, as time goes by. And then you say, okay, what happens if they didn't need it? I did an extremis and they didn't need it. What's the damage you've done? You caused a pneumothorax. You may or may not need, old days you used to have to put drain in. Now, if it's small pneumothorax, you don't put a drain in it. So you just keep an eye on it. If it gets big, you might have to aspirate it or put a drain in. You might just have to do nothing at all. You've caused no damage, but if they're an extremis, which they are, and you put that in both sides, and now they're alive, who cares if they have two chest drains in? Like, they're alive, they're not buried. So I can't stress enough, if you're just not sure in a resus, just do something like that because there's nothing to lose, especially when they're doing CPR. Okay, cool, so that's in. So now we're not stressed anymore, okay? That's stayed in, I'm taking it out. We're not stressed anymore, we're gonna do chest, just quickly now we do a pigtail and a chest drain. You've done an ultrasound, you've done an x-ray, you know there's a pneumothorax. I don't know, you can put a chest tube in, but if it's just air, that's pretty small, isn't it? This little chest drain, this little pigtail. I'd reckon I'd want that in me versus a pig chest drain, just because there's going to be less chance of infection. It's way less invasive. So most people will put one of these in these days for a pneumothorax as opposed to a chest drain. And I would say, if someone wanted to practice, I'd probably still say, no, just put one of these in. And by far we do heaps of these and much fewer chest drains, chest tubes these days. Way more of these for that reason. Comes in a pack like this. There's different packs. This one's got a stiffener. I'll show you this one. There's less fancy ones where you've got to actually do it yourself, but it comes like this. We've got these in the shelf. So the first thing I do is put the stiffener in. It goes in. It goes through the three-way tap because then it fits on. You'll see. It straightens that and then just twist it on like a little lock and that's it done. So now you've got a straight pigtail, so to speak. Bare below the elbows, no watch. Patient clean, I'm clean, consented, all that kind of stuff. That's all done. Cool. So cool, same spot. So you don't have to think too hard. Here, okay, cool, so yep, excellent. So for this one, we go local. So I have my local needle here, but here's some local in my, here's some local with I'm just going to use a long orange needle now, along sort of 24, 25 gauge. And I'm going to put it in, and as I go in, I'm not, same as an LP, for me, I'm not going to inject it as I go. I'm going to go in, and I'm actually going to be pulling back, and oh, there we are. I've got some air coming, I've got bubbles coming back. Okay? So I now know where I want to be. Great. The reason I do it though is I know I'm in the right place. Well, it's just going to go through ribs, so it's not hard, but now I want to put local in that space. Not in the pleural space. If you do, who cares? But in around the pleura, because when you punch through a pleura, that's where they really hurt. So, local, lots of local, bit of a fan, but really it's local, 5-10 mils of it until I get to the top of the skin and bleb up the skin again. And I do the same thing, I then untwist and just leave my needle there. And so I know exactly where my hole is. I know I got into the pleural cavity once, I can do it again, but my pleura is nice and asleep. Okay, so that's really, really important. Otherwise, if you just do the skin, when you punch through the pleura, they'll hurts, and then you've got to dilate it. It's just horrible. So, and if it happens, you can always put local down that needle, but this will avoid it in the first place. So make sure you anaesthetize your pleura as well. Okay, so I've got a little local needle coming out. I'll then use, depending on what, just use the long one because you know you'll get to the space, and I'll do the same thing. I'll just seek it with so a couple of mils of saline attached to this. This comes in the pack. Take out that needle, the local needle, and in goes this one. Okay, don't have to. So same hole, and I'm pulling back on my plunger, pulling back. So I'm pushing the phalanges in, but pulling back with these fingers. Pull. We're waiting for bubbles. This mannequin's totally now been wrecked up, but you can imagine that's where bubbles are coming out. So here, lots of bubbles coming out. Awesome, bubbles. I undo that. You can often hear noise, a bit of a hissy noise there too, because air's starting to come out already. So air's coming out, and this is where I get my wire, totally unrelated, has two sides, obviously. It's got a soft side and a hard side. As a rule, always go in with the soft side, okay? Because in here probably wouldn't matter so much, but in the blood vessel you can actually pop it. You can actually perforate the vessel with a hard side, especially if you're using some force. So just, yeah, if you're ever not sure which side to use, just use the soft, because not all have little loops on the end. Some don't, believe it or not. But yeah, always use the soft side going in. So that's my little introducer. And like you did with the central line, that just links into there gently and feeds in your wire. How far do you go? You're going far enough that you definitely know you're in the pleural cavity. I'm definitely in the pleural cavity, there's no question. So I can stop there, pull my needle out. So holding my wire, and then holding my wire at the other side. Cool, so now I've got a wire there, no problem at all. I get my scalpel, like before, same thing, I go through it again. Edge against the needle, the wire, and pop. Cool, that went through the skin for sure, no problems at all. That's done. And now, like before, I want to just twist it around a bit. Make sure I've got a nice little free bit of wire in the skin so it's not getting caught up. Awesome, no problems. You're doing well. I'm doing well. Good. And this sounds dumb, but speak to your patient. And I like to say, if it's going well, say it's going really well, we're nearly there. Because no, you sit there and you're all nervous as the patient. It's actually nice and sometimes says, are you okay? We're actually doing really well. Because, especially if you are doing well, because then they know it's coming to an end. Or you say, I'm struggling with this, we're fine, I'm just being really careful. But just be honest and tell them where you're up to. Okay, introducer on. Dilator on. When you get to the skin, you just gentle twizzle as you go through, and exactly as you were saying, you just want to go through that pleura. You don't have to go all the way in, you can, but you just want to go all the way in, just to there. So I've felt myself push through the pleura, you feel a pop, and now it's easy to go. Done. That comes out, holding my wire, and then get my pigtail, same thing, wire through the middle of the pigtail, feed up, I'll come out the edge, end finally, maybe, hopefully, yay, comes out through there, feed that in, okay, twizzle, there's all these little holes here, last little perforation, perforation in the tubes through the skin, get about 5 centimetres or so, and then stop. Out comes my wire, out comes my introducer, or my stiffener as they call it, that's out. I don't have to worry about air embolisms, I can be a bit less stressed than the CVC. That's not going to connect well to anything. This pack has a connector, a rocket connector with a connector. That attaches to that, and that attaches to my drain. We'll go through drains tomorrow actually, but probably the time is like that. But that goes to my atrium drain. That's it. Different things you can do here. I It depends. If the patient is a squirmy patient who is not going to do anything I say, it's going to get a suture for sure. And it's going to get, for me, it's going to get a purse string, good enough to be a gentle purse string suture. It's not quite, but it's a 12, 3, 6, 9 o'clock suture, which we can do tomorrow as well. It's not really about this today, but I'm going to suture it down. If the person's this person who says, oh no, I'm very happy to be careful with it, I don't suture them because I get scared I'm going to squeeze this closed if I do it too tight. So I just will loop it up, mark where that is at the skin, and then I'll put a like before, I put a sandwich T-derm.